Welcome to CoDesign Conversations. I'm Liana Mestis, the Deputy Director of CoDesign Collaborative. We are a remote-first, bi-coastal nonprofit with a mission to inspire social change through the transformative power of design. If you're not already involved in our community as a member, I encourage you to become a free access member or a paid member. Take full advantage of our virtual and in-person programs and our publications. One quick housekeeping note, please go ahead and leave a comment, ask questions at the bottom of the page. I'll ask these questions at the end of the program. I want to extend a special thanks to our program partner for CoDesign Conversations. This is presented in partnership with Coforma. I also want to introduce and thank Amy Haymans for her leadership and generosity, her creative perspective. Amy is today's moderator. She's also the CEO of Beneficient. Welcome, Amy.
Thanks so much, Leanna, and thanks everybody for joining us. I am Amy Haymans, founder of Beneficent, and we are a consultancy focused on envisioning better digital experiences, services, and futures in health, finance, and social impact. I'm happy to be hosting this series of conversations, talking with brilliant folks, and we're focused on approaches that both public and private organizations are taking to deliver impact and outcomes. Things that are all important to us, like health, well-being, access to benefits. That's where we'll be focused today, access to benefits. We're going to focus on the ways that design and technology is improving how employers, insurers, nonprofits, and government organizations provide access to benefits. We'll focus on health insurance, benefits and related benefits like SNAP, WIC, and other government services that are social drivers of health. And we're going to explore how leaders are reimagining access to benefits, from awareness to eligibility to the application for benefits to navigation of benefits and utilization of benefits. I'm really passionate about this. I believe that we should design to help people not just survive, but thrive, and that the measure of success of a society is how its most vulnerable are indeed uplifted, and that a human-centered and participatory approach to improving access to benefits is essential to that. I'm very excited for the conversation today, and before we begin, I just do want to acknowledge that some people have recently lost access to their benefits, whether due to job loss or policy changes or other circumstances. And so as we have this discussion, we're extremely sensitive to that. So without further ado, I'd like to welcome Natalie Davis, CEO and co-founder of United States of Care, Diana Griffin, Senior Product Manager at Nava, and Yuhan Sonnen, CEO/Creative Sandpaper of GoInvo. So to start, I'd love to hear from each of you what you think matters most in this realm and where your work has centered. Natalie, I know you specifically are passionate about gathering insights from the real people who get benefits and need benefits to inform policy. Can you tell us about that work?
Sure, and thank you so much for having me today. I'm excited for this conversation. For those that don't know, United States of Care is an advocacy organization that brings the voice of people to the halls of power. We believe that in order to build sustainable policy that really meets the needs of all of us, we actually have to go out and talk to people. And so we approach policy in almost in a human-centered design way of going out. We've engaged now over 30,000 people, over 5,000 hours all across this country, and have a data warehouse now of 115 unique data sets, really mapping the human experience in the healthcare system. Solutions that people want, solutions people don't want, language they use, emotions they have. And we really want to show that there are commonalities, there are shared values across demographics. Often in policy, politicians and otherwise, we're able to tear people apart, and we make it seem like healthcare change and policy change isn't a priority. And we're here to show that it really is, and that we should be basing our change off of talking to people. So I'm excited to get into that more.
Yeah, absolutely. Thank you so much. And Diana, you've done a great deal of work improving navigation of benefits through service design and smoothing the administrative burden and operational hurdles that can crop up and get in the way. Can you tell us a little bit about your approach and your work?
Absolutely. And so the work we do at NAVA is a little bit downstream from what Natalie's been describing. We're really focused on the implementation, where we're making government services simple, effective, accessible. And when we do that work, we need to be working across multiple layers. So there's working at the service delivery layer, where that's kind of working on the simplifying the systems, the processes that the public interacts with to access benefits. And then below that, there's also the program outcomes layer that's looking more end-to-end, implementing policy through the full end-to-end programs and services in the ways that ensure the best outcomes for both the beneficiaries and agencies. That might be looking at kind of thinking about the workflow, the processes from both the beneficiary side and the staff side of the agency. How does that move through the system? How does that ultimately deliver benefits? And then even below that, there's a layer of just like adaptability, that foundational layer where we're working to increase the flexibility and resiliency of agency systems and operations, so that in most cases, like technology and processes can be the enabler of successful outcomes and effective service delivery, not the blocker, which in many cases is still the case. So that's where legacy modernization comes into play. And I know there was a previous episode of these co-design conversations on that topic. But really across those layers, the same core approaches that Natalie described. It's human-centered design, it's service design. We're engaging people who will be impacted. We're considering the end-to-end service experience, and we're validating our concepts and designs early and often.
I love it. I love what you're saying, because you're focused on the person accessing the benefits, but also the people who are administering the benefits. Because oftentimes project work will focus on one or the other, but it sounds like you're trying to weave together and harmonize those in a really beautiful way. So I appreciate that very much. Johan, how about you? So your design studio, GoInvo, does a lot of open source work, which I appreciate, especially around benefits eligibility. So can you share what led you all to do that unpaid work to investigate this?
Hopefully it's paid.
Well, eventually perhaps, but yeah, what were your epiphanies and what work kind of came from there? Yeah.
Well, I mean, here in this United States, healthcare is actually sometimes pretty amazing. It's often life-saving when we're in it. It's always frickin' expensive, and it's mostly closed, right? Because it's this tribal nature of each hospital, each doctor, each healthcare system, invents its own way to do stuff. And that's typically to the detriment of, human health. And the cherry on top is that it's our lives at a stake. And, so the mantra should be, at least, healthcare is too important to be closed for the most part. And, in the eligibility, viewfinder, the open sourcing of that logic sort of opens the black box, or turns that black box into public infrastructure. At least that's the hope. It's not always the case, but that's some of the goal of open sourcing those rule sets, because then it's interrogatable. And that is a crack, not in the low-rise genes kind of visible crack, but in terms of the good kind of crack, so that it allows agencies to open up, so that advocates can then, validate that data, can see if it's working, that private vendors maybe have a shot of loosening some of those business rules. So for us, it's like a critical component of how we just operate in the healthcare software design world.
I love what you're talking about. It makes me think of life-saving collaboration. I make a good t-shirt. I know you like to make t-shirts as well. You're not designing new systems. So Natalie, I'd love to dig a little more into the extensive research that you've done. I am very curious what you've learned in terms of what matters most to people, actual people applying for benefits and using benefits. What are their biggest challenges that you've uncovered, and how do you help policymakers understand those challenges in a way that can influence policy?
Yeah. So, when we started out this research, we really were trying to prove that there are shared values that people have when it comes to what they want out of the healthcare system. And so we found those. And again, through a mixed methods approach of research that I can geek out on if people want to get into the mixed methods approach. But really, people across this country have the 4 shared goals for a healthcare system that meets their needs. Number 1 is that people want the certainty they can afford their healthcare. And the word certainty there is doing a lot of work. It is carrying the emotional resonance of what it means when we don't know if we will be able to afford our healthcare. So it's not just affordability, but it is the certainty that they can. Number 2, people want dependable coverage as their life changes. Right now, if people get cancer, if they get pregnant, if they lose their job during a pandemic, their coverage may not be there for them. And people know that. And so a real, and if you think about it, a real simple goal that people have is that their coverage is there as their life changes. Number 3 is people want personalized healthcare, which to them means what, when, and how they want it. So in their community, having their full body seen as a full body and not a disparate body parts that don't kind of come together, being treated for your mental health or if you're pregnant. So really kind of taking into account people's, life experiences and where they want to get care virtually or in their community or in their schools. And number 4, people want a healthcare system that's easy to understand and navigate. And perhaps that might be the hardest one because our healthcare system is so complicated and people feel that so deeply and want a healthcare system that they can navigate. So those are the overarching goals. It's what we work on every day when we work with policymakers in states and in Congress to build that healthcare system that people want. It's interesting. One of the projects we did very specifically was on value-based care, which is like a really wonky concept in healthcare. It was passed in one of the most bipartisan aspects of the Affordable Care Act, and really was there to help deliver care differently and pay for it differently. And we were setting out to educate a lot of new members and staff on the Hill and out in states that don't know necessarily the promise, the background of value-based care. And so we wanted to educate them on what do voters actually want or think about when they think about this. And we went out and we were able to capture what do people hate the most about fee-for-service, the way that they get healthcare now, they access their benefits. We didn't use the word fee-for-service, but we were able to tease that out. And we said there's a new way of delivering healthcare, of using your benefits. And there's all these pros of this different way of doing healthcare. And what would you like the most? And so we had people talk about them in circle and heat map. And I think it's important because it actually really shows whether you're working on value-based care or not, it's the experience that people want. And what we heard very clearly is, number 1, a promise of time, more time with their doctor, less time finding if their benefit is covered, less time in a waiting room, less time carrying around their own medical record. It's this concept of if you can save them time was one of the biggest benefits I know that people wanted. They really liked being seen as a whole person, understanding that their mental health may be contributing to their back health, and they don't want just a prescription, but they really want to get to the root cause of a problem. And then they wanted to know when they're being sent off to get something different, to get their lab work or their go to a podiatrist or something, that it was all covered in their benefits and that complication would be taken away with better care coordination. Interestingly, so I think that's helpful information on how people want to access the care and experience it. Interestingly, when we said, well, this is real, it's called value-based care, it was the worst performing messages we've ever done. People hate the word value when it comes to healthcare, right? They thought when we asked, they thought it was the bargain basement of the grocery aisle, the Dollar General. But it's language we've been using for over a decade to really talk about a new way of doing healthcare. And it really gets to a point of that we aren't actually speaking in language that matters to people. We're not highlighting the benefits that matter the most to people. And so when we're able to bring that then to policymakers and say, look, your voters may not know that they're talking about value-based care, but these are things you can do to solve these problems of time, of not being able to access their benefits, of getting care differently. and really kind of helping them understand how this meets their voters' needs when they work on a really wonky policy. And we do that with all sorts of stuff, with primary care, with ways that states can tackle affordability issues. So not only are we bringing that voice of people and the data behind it, and but then the policy and the political smart, of course, to make that all happen.
Wow, that is so impressive. And I have about 15 follow-up questions, but I am curious. So Diana, as you hear Natalie talking about all of these findings and learnings about what people want, but you're also doing the work of improving the systems, the operation, the administrative layer, so that these improvements and changes can actually happen. What's the biggest challenge? Like, say we had the answer, like this is going to be the ultimate experience. Like, then what hurdles and challenges do you face, and how do you overcome those in terms of actually making things happen?
Yeah, it's a big question. I feel my answer is a bit of cheating. It's sort of the challenge is the interconnectedness of challenges. So thinking about, you described at the top, when the problem space itself is complex, accessing benefits, there's a whole journey to that. There's policies to navigate, there's finding the information, there's awareness, then there's understanding eligibility, then there's going through the application process. You described that whole journey. And then when at the top, I was talking about working across the layers that go into actually implementing that, the service delivery layer, the end-to-end program implementation, and then kind of the underlying foundational like adaptability of infrastructure, systems, processes. Let me maybe give one example that I think kind of illustrates sort of the connectivity here. So I'm thinking about an example of work I was part of with the VA, and I think our friends at Coforma were also involved there. So this work was working with the VA with the goal of reducing the time it takes to process disability benefit claims. And through research with both veterans and VA staff, our team identified some opportunities to improve the benefits application experience for veterans in a way that would also result in some cleaner data coming in on the claim. And then from sitting with frontline claims adjudicators on the staff side, we learned how more reliable data could actually unlock some business process automations for certain, a subset of common types of claims that had the potential to remove administrative burdens for staff and ultimately kind of drastically reduce processing times. Then we discovered that implementing that automation would require flexible technical approaches to integrating data and workflows from multiple legacy systems and databases. So you can see how kind of pulling on one thread at the service delivery layer is going to lead you into adjacent challenges and opportunities in the next layer and the next layer. So there's the complexity of implementation itself. But I really think a core challenge that goes into even starting the work is really having kind of the small p political buy-in to do something differently, right? To take a bit of a risk and try implementing in new ways, especially when we're talking about buy-in across an extremely broad ecosystem of stakeholders and competing priorities and incentives. It's rare to see the will and the incentive to align for taking risks on new approaches. And of course, it's government. There's a lot of constraints around the way that agencies can spend public funds, and that itself further enshrines low risk tolerance. So on the Nava side, that's why we ultimately spun up the division that I currently work on, which is Nava Labs, where we are actually doing philanthropically funded work. And that's working with philanthropic funding creates the space for higher risk tolerance. It creates space and opportunity for us to experiment and prototype policy system change in ways that allow us to learn and de-risk those approaches, validating them in order to be able to advocate for that downstream adoption in those more constrained agency environments.
Amazing. And I'm just keying into kind of our banner of what our emerging theme here, life-saving collaboration. I wonder, have you leveraged any approaches to sort of head off the downstream challenges that can occur by inviting people to the table of innovation to sort of like get their buy-in ahead of time? Or are there any strategies like that you've seen work effectively?
You're asking for strategies around getting buy-in to kind of begin these approaches?
Yeah, like collaboration early and often. Is that something that works, or do you have another tactic?
Yeah, yeah, definitely encourage collaboration early and often. It's a lot of listening, right? I think this comes back to those core principles of human-centered. Your stakeholders are also people you need to sit down with, you need to listen to, you need to understand what constraints are they facing, what what incentives or motivations or problems are they trying to solve. And then it's kind of the service blueprinting, the service design approaches of understanding the mapping between the different priorities, the different needs, and trying to kind of connect the dots in a way that can get needs met, that can help folks from different perspectives, different needs, understand the ways that a solution that might be different from what they were picturing, or something that isn't what is their typical approach, can still get the need met and can potentially give them the benefit they're looking for. Giving them that through line, through, like you said, through collaboration.
Helping them envision the possibilities. That is really cool. So, Johan, I had a question for you, and we got a question from the audience that's very similar, and it's about persistent challenges, systemic challenges. I mean, you've been working at the intersection of design, technology, and health for many, many years. So what persistent challenges and systemic obstacles do you see? And what do you think's in our power to overcome as well?
Well, the persistent problem is like money, greed, and there are lots of different things. People not wanting to make a decision, people not having the collective backbone to make a decision locally, whether it's in your town, whether it's in your city or state, let alone the Fed. And then the way money impacts our current government system is a huge lever. So, Natalie was talking about, we all talk about the complexity of the system, like it's how painful it is in her research, right? Everyone's yelling about it and bitching about it, rightfully. Well, the complexity allows people to make money, a lot of it, especially at the margins or places you don't see it. The second part is it stops people from actually getting benefit. So the idea should be, no, that crap just comes to me automatically. I should just know. It should just come to me. Benefits should come to me automatically. If you have the luxury of going to another country, you go walk into the UK. I mean, NHS is having its own problems. Switzerland, or my homeland of Estonia. You walk in, and it is a different, like, those problems kind of melt away. then you're like, oh, I can live my life. I don't have to consider, like, well, what the hell is this bill going to be? Is it going to topple me forever? But the benefits should feel a lot more like what Estonia is doing. Is they just show up on your dumb phone or your smartphone, and you know what they are, and you can run your life without the overhead of, do I qualify or not? Screw that noise. That sucks. Mm-hmm. Right? So I'm going off a tangent here, but it's like,
so how do we get there? I mean, what like, are there any small steps or big steps, or, I mean, do you see any levers?
Well, I mean, there are whole. I mean, let's make the assumption that if everyone should have healthcare, or access to healthcare, whether that's some kind of flavor of healthcare for all, or we want to say, hey, Medicare for all. What's that mean? Well, let's get rid of there are ways to get there in small policy jumps. They're still big, but sometimes it's hard to go all Bernie. But you can start with, hey, there should be no disenrollment barriers in Medicare Disadvantage or Medicare Advantage, right? But it's really a disadvantage. There are actually times where you can't disenroll from Advantage and go to regular old Medicare. That's insane, right? Like, we should kill that. Oh, maybe we should think about, well, we should increase the federal poverty level by 4x the current number. I mean, right now, the poverty level that the government thinks the poor should be is like $18,000 a year, $22,000. If you have a family or whatnot, it goes up. But it's ridiculous. No one can really survive on that, in any metropolis or any sub-metropolis on that. So the UBI is something we should also think about in serious universal basic income in some flavor. We've had it before, like the child tax credit. That is a kind of income for those that need it. And we're going to need more and more of that, for better or for worse. To your technological question,
Right.
is you're going to see a lot more services automated over time. We've seen it for the past 60 years. We're seeing it now, a hyper drive in the past 2 or 3. And you can easily see it coming for lots of different types of gigs. And so I think we're going to be hyper vigilant about this because look, when Diana said the VA has known about healthcare for all for the past 75 years. That's, they know it. They practice it for the most part as best they can. What did we do at the end of World War II when Allies walked into Germany? One of the first things was establish universal care. Same thing in Japan. I mean, so intellectually we know it. We just have to have the fortitude to actually make decent and better decisions.
Well, and I think you're touching on something that makes a lot of us feel a little bit powerless, where we might not be in a seat of being able to influence policy at the federal level or at the state level. It becomes more achievable potentially at the local level, but short of policy change, in our role as a leader, a designer, a product manager, tell us something that we can do as we approach any flavor of benefits work that we're embarking in. So say I'm about to start a project tomorrow to improve access to benefits. I'm gonna use AI to improve self-service. Give me a tip.
Well, you could start looking. Let's get specific then, right? Let's say you're working on one of those services we talked about at the beginning, like food stamps for Maryland, for Washington State. If only DC was actually a recognized state. And you wanted to, and you're starting on how do we make that a better service for all, right, in that state. One thing to do is you could actually start to parse the rules that drive that. Right. It's I'm not talking about UI. UI for a lot of this is not typically the biggest problem now. Yeah. Right. So I would actually start to parse at the rule sets that drive eligibility. And you can do that through using AI services and along with your human interpretation, and start to cut down the duplicative nature of a lot of those rules. So if you look at what Massachusetts did, I don't know, maybe 2019, they chopped 30% of the questions off their food stamp eligibility quiz, and about the same, or 22% off the Medicaid, Mass Health, and that shaves off time, to Natalie's point. Right. And a whole bunch of other weird things. But that's the first place to start. How do you work the policy of getting eligible? Right. And that's one thing to do.
Love
Does that
it.
make sense?
Yeah, that's super duper helpful. I'd love to take you there as well, Diana, on thinking about the future, people that are working on improving access to benefits from a product systems design, or even nonprofit influence perspective. What would be either magic wand, what would you like to see happen, or a tip for folks that are in this realm?
Yeah, I think I'm going to kind of walk the line between magic wand and tip. What Johan said earlier around kind of flipping the script from, as a member of the public, it's kind of, I have to go out and pursue. I have to do the work of getting benefits. I think there's opportunity to sort of look at the ways that we can take steps towards a more proactive benefits delivery experience. Thinking about not only, I think I'm repeating a little bit here, but not only kind of improving the experience as it stands, which there is plenty of room to do that, but also as we're looking at that, what are the ways that we can actually change the experience, kind of bypass some of the overall processes and policy steps. So I think I'm echoing both Johan and Natalie here.
I love that. Proactive outreach and service delivery. Like, so what I'm hearing is we make everybody do all the work. How do we lessen that administrative burden? And we wait till they come to us in need or upset. What can we do proactively to sort of head that off? So
Yeah,
you're,
Amy, let me just say that I think
yeah,
what
go ahead.
Diana's saying is, in essence, not just activism, but making things is a bromide, is an antidote to depression too, right? Because we feel like we can't do anything. If you start making things, and it can help a lot, actually.
So I want to end this conversation with someone who's made something very cool. So Natalie, what you've done with United States of Care, if you could play it forward, 5 or 10 years, what are some things that you'd like to see happen? It could be taking a participatory approach to policymaking, leveraging, working, collaborating with real people. Like it could be anything, but where would you like to see things head? Because your literal fingers are on the pulse of what people care most about.
Yeah. What if in 2033, the president of the US signs the first legislation built off of the needs of communities across this country? What if we have a healthcare system that is moving in the direction of those 4 shared goals that people had? And we've done that through really going out and talking to people, helping them tell their own story to policymakers and media, helping build a groundswell of common shared needs of making things easier to enroll in, having the healthcare system be more responsive to all of our needs. My daydream is that happens. And I know I've been called a badass Pollyanna, so I know this sounds Pollyanna, but I really do think it's possible. Every 10 years, this country takes another step at changing healthcare, and that can go in lots of different directions. But if you look at over time, that has been the case, and I think we will have another chance at that. I think we're going to have a lot of stuff that we need to improve with a lot of the policies that are currently happening right now, where we're taking a step backwards in coverage, and so I'm building towards that moment. I'm building that movement. Our team is building that movement with partners across the country to really have legislation that people see their voices reflected in, and is moving us towards that healthcare system that people want.
That's a beautiful thing. And I'm a big fan of participatory budgeting. I've seen it work, at the municipal level. If a town gets $1 million to build a park, that the people who will use the park get to decide what goes in the park, et cetera. So taking that sort of participatory approach to the federal level would be really interesting. And I had the opportunity to work with health policymakers recently, introducing them to human-centered design and futures thinking. And they loved the collaborative mojo about it. And that was just bipartisan collaboration. But what you're talking about is inviting the people whose lives are affected by these policies to the table of innovation. And so I find that hugely inspiring. We do have a question coming from the audience, and now's the time for Q&A. So if any of you have a question, please type it into the LinkedIn Live session. So this question is there anything being done in the space of how solving for value-based outcomes could save taxpayers money?
Yeah, I'm happy to start there just because I brought up the wicked beast of value-based care. It's interesting because when we went out and talked to people about the benefits of the promise of value-based care, we actually didn't put on there, this will save you money, because as we know it, that isn't necessarily one of the promises of doing of this better. The way we've talked about value-based care is that we're rewarding doctors, we're incentivizing doctors to do care differently. We are saving the Medicare Trust Fund, is saving dollars there. And that messaging also didn't work because people are feeling like you're going to pay doctors more to do what they should be doing. And you are worried about saving Medicare and, the government money, but I can't even afford my health care. And so I'm answering the question in an indirect way where I think we can say if you have better, a better experience through, let's say, a kidney company who is using value-based care to deliver care differently. If you are able to prolong or never have dialysis in the center, and you're able to do it at home, or you are able to have a wraparound, I think we can show that would save the individual dollars. But I also think there's a lot of work, especially with what Johanna said about how much people make money off of healthcare, and there is so much profit to be made, that I think we need to do a lot more to show that these policy changes, especially, really impact the pockets of people across this country, because besides their health, that is the number one thing that people talk about all the time when it comes to the care that they want, the benefits that they want to reap, et cetera.
Yeah, I mean, huge fan of value-based care from the perspective of, let's not incent the treatment, just the treatment of sickness. Let's incent a system that helps keep people healthy and vibrant for as long as possible. So it makes total sense to me. And now in this age of AI, I do wonder, Johan and Diana, if you have a perspective around how AI can maybe enable value-based care. I mean, I'm of two minds about it. I think AI could be a low-cost alternative or augmentation to the health system, but things could go very, very well, very quickly at scale, or very, very badly, very quickly at scale. So, of course, we need to put guidelines and measures in place to ensure the protection of humans. But I also see a great deal of potential. So do you have thoughts on that?
Sure, I can jump in. I will say the work that I've been doing on Nava Labs has been focused on experimenting with responsible AI in benefits navigation, so not specific to healthcare or value-based care, but so I'm drawing some analogies here. I think the approaches that we've been taking are thinking about kind of finding the pragmatic way forward. So, removing some of the breathlessness around the hype of AI, but thinking about, these are powerful capabilities. And there are specific capabilities that match specific needs in the space. So trying to kind of dial back from thinking about kind of AI as the magic wand, like it just replaces everything, but more like how does it support or sustain some of these jobs to be done and processes, and ultimately how does it help the people who need to be part of this process. So some examples thinking about the capabilities of generative AI for improving how we handle documents, document processing. That's a huge part of the benefits application and eligibility process, and it creates a lot of pain points. That's a really small slice of the overall problem, but it's also slicing it down in that way, again, kind of coming back to that notion of risk tolerance or risk aversion. That's a way in. That's a way to start proving impact and proving capabilities, and then we can broaden from there. I think I've gotten a little off track of the original question about AI for value-based care. Maybe Johan, I know you're a bit closer to the healthcare space with that.
Oh, I don't know what I'm talking about either, but I know over the past, 2 or 3 years, there's been over 100 public-ish, at least 100. I mean, that's what, I can count on how do we make sure that humans and machines work well together when diagnosing, when treating, when care coordinating. I mean, hell, the moonshot under the last administration was doing it. Now, actually, there's another, thing with childhood cancer that are, it's about integrating machines to help getting patients and their parents, I'm just giving the pediatric cancer example, together, and getting their documentation, just like Diana said, together more easily. And it's sort of sniffing out, okay, let me go look at your data in Epic or wherever it is, and it's going out and finding it for you with your permission, with your consent. That's also another difficult one. And it's doing a lot of the legwork so that you're not there scrapping through, after your kid goes through their junior high basketball game and their knee hurts or whatever the scenario is, and there's a big ring, or that's visible. What the hell is this? And making it a lot easier for them to get diagnosed faster and faster and getting treated faster, and then knowing the costs too up front. The fact that we have to know that is also insane. But there are lots of projects that are doing that, and they're finding that when machines and humans work together to diagnose, to care coordinate, you're getting, points better in both diagnostic rates, meaning it goes from like 84, 85% to like in the 90, 91, 2-3% rate of correctness. And that's pretty rad. I mean, we're getting closer and closer to this like asymptotic, top where we're getting pretty damn good at this, and it's only going to get better. Now, that's a rosy way of putting it, but I think there are lots of projects on this right now, and I think it's going to do wonders for a lot of people.
Yeah, you're painting a good and hopeful picture. As a futurist, I like to envision a positive future and figure out how to backtrack, how to to get there, what needs to be true in order to get there. And I can't help but wonder about creating kind of synthetic scenarios that sort of tests how AI could help us leapfrog how things work. I love where you're going with applied AI for benefits navigation and conversational generative AI for benefits navigation, Diana. And then I love where you're going with for fast and accurate diagnosis, Yuhan. It's incredible. One thing I've been thinking about a lot lately is how AI work slop, homogeneity. Are there any net new ideas coming, and the kind of balance of correctness and accuracy, and then creativity and that which makes us human, and we're designing services and systems that serve humans, right? This is for people after all. Natalie, I have a question for you. Like, as you present, and this will be my final question, but as you present aggregated insights to people in a position of influence, how do you also not lose the insight that comes from not just a stat, but a human story, right?
Yeah.
Because that can really be captivating and move people and even inform us beyond our brain, but our heart, our gut, and perhaps create the motivation to actually do the hard work to make things better. But like, how do you kind of grapple with living in the data of real human stories and then aggregating it up for like decision making?
Yeah, I think you're hitting on exactly the right tension. Really wanting to show that there are shared experiences, shared values, et cetera, to show that people want change and bringing forward those stories. I mean, one that I didn't share when I was talking about that value-based care project is there was one woman who had the best analogy for fee-for-service or our healthcare system, where she was like it's like a high school cafeteria line, and you put down your tray and they slop healthcare on, and you have to move down, and maybe you ask for peas, but they slop on green beans anyway. And like, that was just such a great way of like, nobody's ever described fee for service that way, but it was so good.
Mm-hmm.
And so, we are trying to bring as much as possible those stories forward and quotes forward. I mean, I think we're probably the only organization when we submit, maybe I shouldn't say that, but we for sure, when we submit comments across states and to the federal government, we have quotes that back up all of our policy recommendations to really show the human experience. And, I think as we think about our organization becoming more resourced and partnering with other organizations to actually let people then tell their own stories in the right places with the right support. Because it's actually even better than us telling those stories is having people come in the right halls of power and in the right way, be able to share their own story. And that, especially for a policymaker when they're in their district or they're in their state, is extremely powerful. And I think a real, obviously, way to put a human spin on it, because it is coming from humans.
Mm. And that's the core of people-centered design, human-centered design. And I mean, we've really explored the gamut here, from policy to systems to technology to products to experiences to AI. I'm so grateful for each of you and the work you do every day to improve the experiences of people in the United States. So thank you for being here and the work you do.
I want to echo Amy, and thank you, Amy, so much for moderating this conversation. Thank you, Yuhan, Natalie, and Diana. This conversation is so inspiring about both the challenges, but also the opportunities and the role that design plays, which I don't know that necessarily a general stakeholder or everyday citizen and individual is thinking about in terms of it's the critical part that it can play in shaping how people can have access to very basic and essential needs. So I want to thank you all for being part of this conversation, for sharing your expertise and your insights. And again, CoPharma, our program partner, for sponsoring and making this program possible. Thank you to our audience for attending. Please get involved in our work. Learn more about CoDesign Collaborative at codesigncollaborative.org. Become a member and also follow this program series. We're soon to announce our next episodes on healthy futures and operationalizing AI. So stay apprised, follow our work, and also get connected in with GoInvo, United States of Care, NAVA PBC, and again, CoPharma. Thank you all so much for participating, and we look forward to seeing you at our next conversation. Goodbye.